the presenter mode or?
Nope.
We are good. No, you're good. This is perfect.
Perfect. Awesome. So yes, I am Maureen. I'm coming to you from the University of Kentucky. We'll talk about scapholunate ligament injuries today. So just to, give you a little bit of a background where I'm coming from. In Kentucky, we have bourbon, horses, and basketball. So I've already been courting Joe to come and join us here. But if you guys ever want to come and check out what we've got, how many hours? 6 hours north of you. It's a pretty exciting place. We're like sort of, you guys, I think your practice mix, we have a lot of trauma, a lot of things like that. So I think it's been fun to get to know your attendings, and we've all sort of grown up together and sharing some of our stories and things. So I'm going to go a little bit quickly because I think our audience here is relatively high level of training. So and I've got a lot of information, so I'm just going to kind of abbreviate it so we can maybe get to some of the more controversial and fun things to talk about. So scapholunate ligament injuries are a huge spectrum. They're also very controversial, difficult to manage, and don't have great outcomes. So this is why you're going to see lots of lectures if you go on Handy, which is a great platform for the residents that are watching this on an abbreviated version. Handy has a lot of, lectures and articles or videos about this topic, just because it's something that we as hand surgeons really struggle with. It can be really fun and we enjoy treating them, but they don't have the best outcomes. And so, not every SL ligament is the same. You've got a high energy motor vehicle accident, a football player gets tackled versus sort of a low grade injury. And then there's a subtle to an obvious injury. So not all of these are created the same. So this is why we'll go into some depth with this. As we know, the scapholunate ligament is very important for carpal stability, and chronic injury leads to DZ deformity. So just a little bit of the anatomy. We're all relatively familiar with the ligament, but I think it always helps, even when you're a fellow or even attending, to just kind of go back to the basics a little bit and think about the ligament and hear some of these things again. So I think what I found most surprising when I got to be able to do the operations myself as a resident was to actually visualize the ligament and see how it looks and feels, because it's not a ligament like we're used to. It's not like an ACL, where you can feel it and things. It's sort of this broad insertion between the two bones. And when you look at it under, arthroscopically and probe it, it's just that soft space between the bones, but it almost looks contiguous. And the same thing when you sort of do an open. So I would just encourage you guys to take a little bit of time to always show your junior residents as you're walking them through these cases, just point out that the ligament is not what you normally would think of, because it is such a distinct one. Remember that at the SL ligament, the dorsal components of the fibers are the strongest. The LT is going to be the volar component. And so that's why a lot of our reconstructive procedures for this have focused more on the dorsal reconstruction versus the volar. And remember that the SL is the key to connect the scaphoid and the lunate, which makes the perfect motion within the proximal row to articulate with the mid-carpal row. Also important is to remember that the ligament has proprioceptive Pacini nerve endings in it. So the integrity, the health of the SL ligament helps us understand where our wrist is in space. It does have very important properties to it. So incidence of ligament injuries from the acute injury, we know that about 10 to 30% of distal radius fractures are also going to have a scaphoid lunate ligament with them. And then I think what's really important to point out is the degenerative injury. I think all of us kind of know this, but the layperson doesn't. And I wouldn't believe when I'm pre-screening my clinic, all of the ones that are, wrist pain, MRI, SL injury. I'm like, oh, this is going to be a juicy. And they're a 75-year-old patient that had a fall and has a slack wrist. And so I think that's, important to understand that when we're looking at longitudinal studies, about 50% of people over the age of 80 are going to have an SL complete tear. So it's just a normal degenerative process of the wrist. And that plays a huge role when we get to talking about management of these injuries. A little bit quickly through this about, just the tendency to have an SL injury is to have a fall into a wrist with it extended and ulnar deviated, and then it has that screw-vise mechanism where the carpal bones are locked, and the capitate then kind of pushes through down into the lunate to disrupt the scapholunate ligament from the distal to proximal direction. We know that as the ligament disrupts, the scaphoid goes into flexion, the lunate into extension, and that's why we have the dorsal intercalated segment instability, the DZ deformity, which is describing the position of the lunate in relation to the wrist. I'm just checking to see if we have some more residents on here. Maybe a few have gone in. So one thing that I like to always sort of tell the residents when they're talking about test taking skills, which can be helpful for you all, is that, you know, is it DZ, is it VZ? And I kind of learned to remember this, that scapholunate is DZ, and it's so much more common. So if you just sort of remember the most common one, then you can back your way into remembering that a VZ deformity would be an LT injury, which is extremely uncommon. And so the DZ position leads to an abnormal flexion, and it progresses to a known form of arthritis. The clinical presentation, so pain and swelling over the dorsal radial wrist tends to be worse in extension. They may have decreased grip strength. They might talk about the popping, catching, clicking in their wrist. And some of these exam maneuvers have a pretty high false positive rate. I did want to mention one of the kind of arts of medicine that I am coming to appreciate. I think most of you know, but just in case you don't, that the scapholunate ligament has an association with the dorsal ganglion. So dorsal ganglion tends to come off of the SL. People will notice and come to your clinic with sort of a new dorsal ganglion or more sort of dorsal central wrist pain. And if you kind of ask them, hey, say, did you just recently pick up yoga, you know, if they're a female, or CrossFit, or push-ups if they're, you know, male, and they're like, oh my gosh, how did you know that? They think you're a magician, because we know that bearing weight with the wrist in an extended position is what really hurts the SL ligament and kind of what makes the ganglion pop up sometimes, or just pain the dorsal wrist. So if you want to look like, you know, a mind reader to your patients and they think you're just amazing, you know, sort of before they tell you, you know, what's been going on, if you just ask them about it, it's a pretty good chance that it's going to come up. So the Watson shift test, this, you know, they kind of like to ask about it on the test taking, sometimes about the exam maneuver. I will be honest, I actually really hate this exam or this maneuver. I think it hurts everybody. I very rarely get that clunk. So for me, I really hate the Watson shift test. X-ray super important. Obviously, we want to get good, you know, PA and lateral views. You may see the static changes. So having SL widening of 4 millimeters or greater than 2.5 millimeters compared to the other arm. You might have the cortical ring side short scaphoid sign. I'll also kind of some of this increased radial lunate angle or SL angle. And this is what some of those can look like. So then we talk about additional views to really assess what the ligament is doing. So maybe they have wrist pain, x-rays are negative, but you're suspicious for an SL ligament injury. That's where you can get stress views. So I personally like the PA clenched pencil view. I think that's a pretty helpful one to get. I do find that x-ray techs have a problem with getting a good view of this. They tend to have the wrist go into extension, so it's a little bit tough for them to do. But here I would put in some plugs for your mentors. Dr. Wagner has been talking about, Dr. Sue has been evaluating your DDR imaging of the wrist. And I'm excited to learn more about what this is going to do for us in the future to be able to get a better assessment of what's going on with radiographs versus needing advanced imaging. So what are we trying to avoid when we're treating an SL injury? So it's the slack arthritis. And I really like to talk to my patients about it being as if your tires are out of alignment on your car, that when they're not all sort of perfectly fixed, they're going to wear out faster. And I think that's a sort of analogy that patients can really understand when you start to talk about, even if it's, you know, acute injury that we're repairing or sort of more this chronic reconstruction. I think that's a really good way to kind of get the patients to think about it. Quickly to go through the Watson classification. Stage 1, you only have arthritic changes at the radial styloid. Stage 2, you have progression through the entire scaphoid fossa. Stage 3, you start to get arthritis between the proximal row and the midcarpal row. And the stage 4 is sort of controversial. That's where you have pancarpal arthritis. A lot of people will say that this doesn't actually happen from an SL injury. It's got to do with an inflammatory arthropathy or a gout, but just there for completeness sake. Note that the key to all of this, and very predictable for slack or for SL pathology, is that the lunate facet of the radius is spared. So the articulation, I'm not sure if you can see my mouse or not, but the articulation of the lunate with the radius, that lunate facet is spared. I did a degenerative wrist arthroscopy a couple weeks ago, and it was amazing the step off. He had slack wrist. You know, the scaphoid facet was completely eburnated. It was like porcelain bone on bone. And there was this cute little hump, and then the lunate fossa and the lunate were just perfect. And it was a great picture to show my residents just about how this typical pathology progresses. And it's key to how we can fix these on a delayed basis. I put in here arthrogram. I think it's very much a historical perspective, but I do note that now we are starting to get more and more gray hairs, Nina and Mike and Paul. And so for us, you know, we learned about these, and I think it's important to pass it on to the younger generation, because if you don't know history, you're destined to repeat it. And I do think it's important to know what our predecessors did before they had MRIs and things. So they would do an arthrogram where they would inject contrast into the wrist and take the x-rays and see if there was communication for an SL tear, a TFCC tear. And so these, you know, were something that were done. I think at this point, no one's really doing them anymore, but important to know. They also did cinearthrography, which I think is sort of what you guys are developing with the DDR, and be interested to hear more about that. MRI, MRA, MR arthrogram are still kind of, you know, our go-to that we like to use as hand surgeons. They're pretty good at looking for carpal, you know, ligament injuries or TFCC tears, but not perfect. But they are something that we go to. I would say by and large, the definitive agreed upon gold standard for SL ligament pathology is arthroscopy. It allows you to directly look at the ligament, probe it, assess for how much gapping there is and things like that. So the Geisler classification from Dr. Geisler down in Mississippi describes the stages from 1 to 4, with 4 being sort of the drive-through sign where you can drive an arthroscopic camera through the ligament. And then you guys are very familiar with arthroscopy. I think you're very lucky to be training with some of the leaders in our field, pushing the boundaries of wrist arthroscopy for the ligament. But just to revisit, you know, how this looks. This is kind of a, you know, nice picture of what I was talking about as far as the ligament. It doesn't actually sometimes look like a ligament. You just see the two bones and the confluence between them. Finding the ligament of testudo in the back of the wrist is sort of, you know, your lighthouse of the wrist, where you can find the SL ligament right above you. And that's really important. I'm sure your mentors are teaching you about that. And here's just what it's showing, the probe to assess between these. So moving on a little bit into treatment, it's based off of these factors. And this is where sort of the nuts and the bolts of kind of the talk and the discussion gets into. All of these things matter and come into play. Is the injury acute? Is it chronic? Is it static versus dynamic? Meaning, you know, on the plain films, is the bone sitting there, or is it gapped open? Is the gap reducible or irreducible? Can you pull the scapula and the lunate back together to be able to fix them, reconstruct them? How much arthritis is there, and also the patient functional status. So all of these things are super important to get to know about your patient, about the injury when you consider treatment. I really like, there's this yellow journal article from 2015 that was sort of just a review of SL injuries, but it has a really nice algorithm. I'm going to spend a little bit of time on this because I do think it's maybe a little bit different than what you might be learning based on our talk that we had in San Francisco recently. And I'm going to go through this because I would say that this is probably what most hand surgeons, I think, how they think about it. So I'm just going to go through this with you. I'm sorry, I broke it down into some screenshots, so we'll kind of go through it a little bit slowly, since I know it's a big diagram. So you have a patient. You think the injury is acute, just happened. On the x-rays, are they negative? Get an MRI or an arthroscopy. Or on the x-rays, do you actually see, you know, the SL diastasis? Do you see the gap? From there, you might go straight to surgery versus doing an MRI or arthroscopy. And then sort of getting down, you know, somebody that's going to have changes on the x-rays is not going to have a partial tear. So they're going to have a complete tear. And for this, you're probably going to do an acute repair, sutures in the ligament, and then potentially a K-wire screw to fix it, plus or minus a capsulodesis. We'll talk about this more in a little bit more detail. If it's a partial tear, you know, you can think about strictly immobilizing them, doing an arthroscopic kind of debridement or even a thermal treatment, which I'm a really big fan of, but you don't necessarily need to put a suture through it. So this is sort of the more accepted gold standard. It may not be what you're necessarily knowing about in 2024, but this is sort of, you know, a little bit black and white of how you might treat an acute injury. So then what about we think it's chronic? Chronic is debated. x-rays. No instability, you might want to think about stress x-rays, or you already see that there's that gapping, just get your plain x-rays. And from here, you sort of go down the same steps as far as getting the MRI, doing a diagnostic arthroscopy. But here, notice that when you talk about, a chronic injury, if it's low grade, you could still think about doing debridement, pinning, capsular, heat shrinkage treatment. High grade, you think about a reconstruction. So moving on to the other side of the chronic, where they already have the increased, so they have, a static deformity already, they have the increased SL gap. You maybe at this point, can avoid getting an MRI or doing an arthroscopy. So if there is arthritis, you want to do a salvage procedure, PRC, four corner fusions, something like that. If there's no arthritis, consider staging arthroscopy and then do a reconstruction. So this is sort of the thought process and how we go through all of these. And there's a lot of debate within all of this, but just to kind of put it in perspective. So what does the evidence say? So an acute injury, partial tear, they do pretty well. Casting with some thermal treatment. There's an article with 4-year results of patients with that Geisler 1 and 2. They do well. Good range of motion, good pain relief. Complete tear treated acutely, and they define that as less than 21 days. So pretty decent, 13 out of 18, excellent, 3 out of 18 with good results at a 3-year follow-up. Patients in this group had a capsulodesis and a K-wire if they were over the 21-day repair group. So how do I do an acute scapholunate ligament injury repair? So can I say it? I do an open approach. I don't do it arthroscopically. Dare I say that in front of my colleagues here? So I do, a dorsal approach. I do a formal Mayo wrist capsulotomy ligament sparing. I like to put K-wires in his joysticks to help reduce the interval and help bring the scapholunate diastasis together. I prefer to use absorbable suture anchors because for me, I like the thought that they, with time, will sort of absorb, and I also like that it's not going to interfere with an MRI in the future that the metal anchors have. Although just to kind of bring some more controversy into your world, the absorbable suture anchors, there is some debate. Do they cause more osteolysis? How do they actually do in the small bones of the hand? So I think that's something we'll know more about in the next 10 or 15 years. A direct repair of the ligament. So the suture anchor goes into whichever bone the SL ligament ripped off of and bring it back down. I do like to add a black capsulodesis for my repairs, and I do K-wires, which I will generally bury so that way I can get the patient moving and I can leave them in as long as I want to. So anywhere from kind of 6 to 12 weeks, which is something we can also debate if you guys wanted to at the end. I also tend to, especially for perilunate ligament, where it's no bony changes, but a perilunate dislocation, I like to do this diamond pin configuration that I learned from one of my attendings when I first started here at Kentucky. And so that's where you do an SL pin, LT pin, and then 2 pins from the scapula on the triquetrum into the capitate to sort of bridge the fixation construct. And I think that works really well. I bury these and then come back to the OR to take them out because that's kind of a lot of pins to go fishing for in clinic. And this is that black capsulodesis. So basically taking your ligament sparing wrist approach, which I think you guys will do and I enjoy doing, and then you bring the ligament repair up through that. So I'll take some of my suture tails, bring it up through the ligament as I repair it down for a black capsulodesis. So then getting a little bit again to this chronic injury, is it a partial or complete tear? Is the interval reducible? Is there arthritis? If it's a complete tear, interval's reducible, there's no arthritis, you can think about a reconstruction. If it's a complete tear, not reducible, or arthritis, you have to move on to a salvage. So what are the different options here? So complete tear, no arthritis, reconstruction. You can do capsulodesis alone. You can do the tendon weave procedures, which is a Brunelli technique, modified Brunelli, the slam, which is a scapholunate axis method, a reconstruction. There's tons and tons of way to do this. And as we know, when there's lots and lots of, techniques to fix something, it means none of them works all that well. So I would say as I've gotten, a couple years into practice, and I ask older surgeons when I have a chance to come across them and just want to, have something to talk about at meetings. A lot of them will talk about the Brunelli. I've heard the Brunelli, modified Brunelli from more people than I've heard any other technique to fix an SL. So I think there's really something to be said for it. I haven't done any, in my training or in practice yet, but it is something I think has kind of stood the test of time. And so this, you take a slip of the FCR and weave it through the scaphoid to reconstruct it. They do okay. So, one of these results had, 1 year follow-up, 13 patients, good results, but they do lose range of motion and they do all stretch out. So it's not the best surgery. The 3LT was popular, sort of when I was going through fellowship. It was kind of a hot one with a 3-ligament tenodesis, where you sort of do a modified Bernal and you bring it up through the DIC and DRC. This BTB reconstruction, I haven't heard, much of in the past couple of years, but it's sort of the thought of sort of doing an ACL with a bone plug and put a vascularized piece of, or a piece of ligament with bone plugs into each of the bones. This was sort of a cadaveric study assessing the modified Bernelli and the SLAM to black capsulodesis, showing that they better reduce the interval in a biomechanical study. The RASL, reduction and association of the scaphoid and the lunate. This is where you basically, you can repair the ligament with what you want to or not, and then put a cannulated screw between the scaphoid and the lunate. It's known to have a fibrous non-union or sort of a neoligament that forms, and then the screw is removed or just allowed to break over time. And this got a pretty bad rap, and I think sort of fell out of favor. As I was still in training, people were just kind of knocking this. But my senior partner that I respect a lot, he now does only P's, but he, in his practice, went to doing these. I've yet to do one, but I'm intrigued. The more of my SL recons that fail, and I'm like, maybe I should go back to the Brunelli or the RASL. And so, I'm sort of intrigued by these and would be open if anybody has any experience with them. So the internal brace is what I started doing out of fellowship. So this was really popular when me and your partners were going through. It was a all dorsal reconstruction. It was sort of the, I'm not sure if you guys can use trade names, so I won't use them, but it's using suture anchors that have a ligament, either autograft or allograft, and a suture tape to go between them. And then you can also bring one limb up into the scaphoid. For me, I don't do these anymore because I had several that just sort of stretched out and failed. I didn't like how big the actual suture was. They do have a smaller one now, so I might move back to it. But for me, I have not been very happy with the outcomes of the internal brace. And this is just sort of what one of those looks like. So then the 360 degree, I think, is sort of one of the more popular ones right now. It's just sort of got about 2-year outcomes in the literature. It's gone through a lot of different names, so I can never quite keep up with what we're calling it these days, but it's been called a 360 around the world, an ANAFAB, anatomical front and back. The most recent one is calling it a slip procedure, scapholunate ligament internal brace 360 tenodesis. But the thought process with this is you actually do a dorsal and volar approach, and you recreate, the normal anatomy of the ligament, which is to do both a dorsal and a volar reconstruction. It's not really for the faint of heart because you do have to do an exposure through the carpal tunnel. So I've done a couple with these with my partner, and one of us is on each side, so that as we're passing the drill through the carpal tunnel, there's an experienced set of hands on either side. This is the most current longest term outcomes. So in their series, they've got 9 patients, kind of, young there at age 45. I'm going to say that that's young. And they had an average of 34 months, but a minimum of 12-month follow-up for their group. Overall, they found that the flexion extension was improved, grip had improved, and I think most importantly that we look at with scapholunate is the reduction holding. Is it gapping back open, or is your reconstruction actually staying? And so they, had a good reduction from 5 millimeters to 3 millimeters in their series. So this is one from the series where they show, that it actually did stretch back out, but they said the patient was asymptomatic, which is also something to talk about with SL, reconstructions, is if they gap, doesn't matter. There's just some, pictures from their technique. And so I kind of like this because it's showing you where the bone tunnels are, and you can see sort of this in figure C, you see the kind of 2 end-on-end wire holes where you see the suture anchor that the ligament, that the palmaris autograft and suture tape are going through. And you can see on the lateral view in D, you see that path where the drill was to try to help reconstruct in theory, the native SL ligament. So I've done a couple of these. Unfortunately, it's hard to remember to take pictures when you're doing a cool case. You start out with a couple, and then as the case gets more involved, you just stop taking pictures. So as of yet, we're still kind of, involved in the technique and don't have the best photos, but I will someday. So here is getting the drill starting points. You can kind of see on the AP, the pin that's going through the scaphoid, that's going to be the drill tunnel there, is going from a dorsal distal to volar proximal direction. And on the lunate, it's straight A to P. And important, you get the kind of guide wire set and then you drill over those and pass your suture tape through it. And then here's a picture of us going through that carpal tunnel, passing the ligament. You do have to pass it 2 times through. And so you're going around the world 360 to reconstruct this. And this is kind of what it looks like at the end. You can take that limb up into the proximal scaphoid, and you can also take a limb volarly down into the radius to try to reconstruct the RSC ligament. Has sort of been a little bit of addition to the technique lately. And that's what my patient looked like on the plain films. So I wanted to get into something, that I get sort of excited about or like passionate about when I think about scapholunate ligament injuries, and that's the role of arthroscopy. So this is something that I think is unique to kind of the way that I was trained, and does fit into that algorithm, but I'm noticing as I talk about sort of specifics of cases with some of my colleagues, not everybody does this. And so I think arthroscopy is super important as a way to talk about the patient, because here's the common situation. You've got a 35, 40-year-old, patient. Let's say it's a guy, he picked up CrossFit, had a little bit of wrist pain, then all of a sudden he went to do, a crazy, lift, and he felt a pop in his wrist, a whole bunch of pain and swelling. MRI and the x-ray show that there's an SL tear. But you're thinking, it's not like you had a motor vehicle accident. You were just, working out. Was this a degenerative tear that then finally ruptured? Or was this injury bad enough to cause an SL tear? And that is, I'm sure that, Mike and Nina and Paul can agree. This is a very common situation. They're convinced they had no wrist pain before, but you're like, you're in the age group and it's tough. And so I think the arthroscopy is super helpful to look in the wrist of the patient. You can tell what's left of the ligament. Is it an acute tear? Has it been going on for a while? What does that ligament look like? You can look at the cartilage. Is there already wear and tear to it? Is it a pristine wrist? You can also assess the reducibility. Can I bring that scaphoid and the lunate together, either with K-wires, under fluoroscopy in the OR, or just sort of probing it with your probe arthroscopically? And it allows me to better have a discussion with the patient. It does mean a second surgery, but, for me, I like to take it slow with a scapholunate ligament injury because, we talked about those reconstructive procedures. They are not easy procedures. They are not a quick recovery. They are not great outcomes. And so allowing that arthroscopy gives me the chance to kind of, okay, here's all this information I just gave the patient. We can, we can fix it. We can reconstruct it. We can do a salvage. Here's the time frame of it. But this kind of, you do a simple arthroscopy, you get more information. You can also figure out what kind of a patient they're going to be. They can be like my extensor tendon patient I had last week who continued to do plumbing with his extensor tendon repairs and a cast, and he tore it all over his repairs, and you get to know that, right? Are they a patient that's going to keep their cast on? Are they going to have a ton of pain? Are they going to, be asking for disability paperwork? It helps you get to know them so you can figure out which of these pretty complex, involved surgeries are going to be the best thing or help you give them more information for that. So I think that this is something I just get excited about is, the role of arthroscopy. So I'm going to kind of go pretty quickly for this last little bit so we can have some time for this debate. But, with the reconstruction, all of these, the salvage, it's all predicated on the intact linear facet. So here's one of my cases. So this is a patient that had some wrist pain, and here's a dynamic view, and you see the gapping between the scaphoid and the lunate. Happened at work. They're in their 40s. But you see a little bit of beaking at the styloid. You guys appreciate that? So even though they sort of say it just happened, they just felt a pop, I was a little bit suspicious. So we kind of, decided to keep an eye on it. We talked about scoping it and doing a reconstruction. They decided to just wait. Eventually, pain got bad enough that we went in and I did an internal brace. So this is sort of it looked better than this, but it gapped right away, which is also why I've gone away from using the internal brace. But we decided to try the reconstruction. It was sort of my third or fourth one I did. In practice, I really got the technique down. I got my graft really slim. I got really great anchors, and it just gapped right open. And so, with time, it progressed. And so you can sort of see what can happen with slack arthritis. This is another patient that has, comes in with wrist pain. This patient does not say it just happened at work. They've known that it was there for a while. So you can see that they've got bilateral changes on these x-rays. So options are a four-corner fusion, proximal row carpectomy. Kind of skip through some of this stuff for these patients. So back to my patient that I did that internal brace on, they ended up going for a total wrist fusion. We talked about some of the other things. They just wanted one more surgery and to be done. And surprise, surprise, they still didn't get better with their total wrist fusion because it's workers' comp. And now they have their permanent disability. And that's the end of that story. So arthroplasty, is an option for salvage for these. It's relatively debatable. I think I'll leave that for another day, but know that that is an option and may improve in the future. So what about other options? This is one I want to bring up because I do think it's something that maybe gets missed in your complete hand surgery education, is a radial styloidectomy. So the goal here is to just unlock the styloid, the radial styloid, and that very tip of the scaphoid facet for slack arthritis. So how much do you take? What ligament do you worry about? What's a theoretical described complication? I think these are really good questions for the fellows or even the residents. But so you don't want to take more than 6 millimeters in theory. And that's for the integrity of the RSC ligament. And the theoretical complication is ulnar translocation of the carpus when you lose that stabilizing radial sided structure. Just to make things complicated, one of my mentors at Stanford, Dr. Hentz, told me that he never saw that happen. You can take as much stylet as you want. All of this stuff is kind of BS and it's hypothetical. So I don't get too worried about how much I take anymore. But know that that is sort of what the test taking principles are. So what about denervation? I think you guys are getting an education on this, but I sort of put it in here for completeness sake because not everybody has been trained in this and sort of is a fan of it. But partial wrist denervation is removing the sensory innervation to the radiocarpal joint or potentially the DRUJ with a selective elimination of the terminal nociceptive fibers of a sensory nerve. So the one that I think me and your attendings like is a sort of partial wrist denervation where we go after the AIN and PIN. And this was developed by Dr. Berger at Mayo, who came up with this technique where he did his own anatomical studies and found that the AIN and PIN give 75% of the fibers to the central wrist. And so by taking just those two, instead of doing a complete wrist denervation, you're able to get a really good denervation effect. And so this is a simple procedure. I just did one today with a styloidectomy. I think it's a great way when you're faced with a bigger procedure to kind of let them get to know what it does. And so I think this is, a really helpful tool to have in your tool belt. So we looked up Dr. Berger, Dr. Kakar's series, just looking at denervation with no other surgeries. There was about 100 wrists with 2 years of pain relief for the patients that ended up going on to a second surgery, which is only a third of the patients. So these patients do really well. So that's what this patient of mine had. We did a styloidectomy and a denervation for them. So just to close it up with some controversies, and then I'll sort of open the floor here. So just two that I wanted to bring up. So the first one, will the ligament injury progress? I bring this up because this is my partner, Dr. Klumper, and he trained with Dr. Osman at Philly Hand. And so he had a patient that when he kind of first started and he kept picking my brain about it. It was one of our D1 football athletes that had an injury, of course, imaged at the end of the season. They probably, ruptured it, 4 months prior, who knows, but complete tear in the x-ray, complete tear in the MRI. But the question is the chronicity. Did this just happen? Could you open it up and just put a suture through it? Or had it been going on for a couple of years? You can't really tell. And then the interesting thing was the recovery time. Because if he goes on and has, a reconstruction, if it is more chronic, which we thought it was, the wrist motion is not going to be great. How quickly can he get back to full on contact sport? I think he was a junior. He was kind of trying to get drafted to the NFL. And so Dr. Klumper and I started having this big debate about, well, just because you have an SL tear, that doesn't mean you have to do something about it. And I was like, what are you talking about? Of course you have to do something. And he said that Dr. Osterman would sort of always go on and on about, we don't know the natural history of this. We don't necessarily have to treat every one of these. So I thought that would be sort of something we could talk about because for me, I hadn't really thought of that. It was sort of, I thought we should fix all of them probably and leave it up to the patient to decide yes or no. But it was sort of an interesting thing to get into that debate. So then my most recent kind of, big confusion and question is, when is it too late to repair the ligament? That algorithm I went through, I took a lot of time going through that with you guys. That's the way I think about SL ligament injuries. That's the way I was trained. But then Dr. Wagner was showing his arthroscopic series that you guys are doing. And I was watching, and you're sort of repairing a more chronic injury so long as there's a ligament there, which to me was like, what are you talking about? You have to do these other reconstruction if it's chronic. You can't just put a suture through it. And Dr. Kacker kind of weighed in, and he also said that he's not really putting a timestamp on things. And so for me, that was really sort of paradigm shifting. And I would love to, debate more about that if somebody is interested. So on that to, invigorating, highly debatable concepts at the end there, I will end my slideshow and open the floor to any questions, concerns, comments.
Dr. O'Shaughnessy, thank you. Great talk. I feel like SL is one of those things that the more I learn, the more questions I have about it. So it's always good to learn more about SL. I have a question that is something you touched on in the beginning that I still haven't totally figured out how I'm going to handle in practice, which is the distal radius fractures that present with SL injuries.
Oh man.
And the ones that, you think, not the ones that are like, totally slack and it's obvious it's been there for a while, but the ones you think, this actually could be acute. Maybe there's a little bit of early arthritis. What is your algorithm there?
Gosh, I need to add that to this talk because that is a whole nother thing. So what's really funny is when I started, there hadn't really been much orthopedic hand surgery at my institution. And so I came and all the trauma people started like immediately flooding my clinic and my inbox with like every distal radius that they thought had an SL tear. And I was like, well, I don't know, like, what are you supposed to do with these? And so I kind of like got nervous and like wanted, I don't know. So I sort of went back and forth, and then I really got into the literature too, which by the way, there's not great literature on this. And it's really debated. I reviewed a really great paper where they looked at a big series. It was blinded, so I don't know which institution it was from. I think it was in Europe, where they had like hundreds of distal radius fractures with the SL, and sort of watched them to see if they progressed. And basically they didn't. So it's pretty tough. The other thing is if you're going to do arthroscopy with your distal radius fractures or not, because I think some of your attendings do it. For me, I don't. I think it's a lot of extra setup, and I do pretty well with just, an open distal radius reduction. But if you're going to do, that's the great role for arthroscopy, is you can look at the ligament and you can tell looking at it, is this a fresh tear? Can I put some sutures through it? But I don't have a great answer for you. I think it's a really tough one. And it's going to be the young patient that you worry the most about. I think somebody in their, 40s and older, probably let them ride. I think one way to handle it is to have a discussion with the patient and say, look, we think there's this ligament injury. If you want, I can, make two approaches. I can fix your wrist, and then I can look on the back and see what it looks like. And I can open it up, and if it's torn, I'll put some sutures through it. Or if you just want to leave it alone, and if it ends up being a problem, we can fix it in the future. I did that for a couple, and I looked at a couple. So that's kind of one way to think about it too. Great question.
Another kind of related question: when you are acutely repairing an SL in a perilunate, do you still do a capsulodesis, or do you figure because it's a perilunate, they're already going to get kind of stiff, and you're diamond pinning them anyways? Do you go for it?
I have. And yeah, I wonder about the getting stiff versus the, healing. So far I have, because I do think it adds an extra bit of protection to it. But you're right, sort of, and you have to counsel all these patients about the stiffness. And maybe you guys are getting better outcomes with arthroscopic, than we're doing open, but yeah, stiffness is a huge problem, especially with the perilunates.
Yeah. Yeah, I've wondered, like, similarly to the knee with ACLs, now we have all this compelling literature that repairing someone's ACL doesn't actually affect their long-term rate of developing knee osteoarthritis. So you wonder, okay, if we're repairing the SL acutely or chronically, is that changing the natural history of their disease or not? And I don't think we necessarily have like the outcome data to show that.
Especially because it's so heterogeneous, you know, there's such a huge spectrum of injury. And interesting too, they're also talking about primary repair of ACLs again. Have you guys
Yeah,
kept
like
up
a
with this?
bare implant and all that.
Yeah, like I thought we just put out, you know, grafts in, and now all of a sudden they're talking about repairing them. I thought that went out of vogue in the 80s, but yeah, it's things all come back around.
For sure. As sort of a random aside, how do you do your styloidectomy? Do you do it arthroscopically? Do you do it open? When you combine it with a denervation or?
Yeah, so I do it open. It's interesting, there is very little written about styloidectomies. Because I think, I don't know that I actually did any in fellowship, and then I liked the idea of it. And so I started doing them. I like went through all my textbooks. I'm like, how do I do a styloidectomy? But so what I've found that works the best is do sort of just like a Descurvain's approach, because they generally have Descurvain's sort of irritation just from all the stuff on that side of the wrist. Release the first compartment, go in the floor of the first compartment, because you have a pretty good safe space where you know, okay, I'm not on the radial artery. The EPL is out of the way because I'm kind of here in the first compartment. Then I like to use a K-wire to mark the osteotomy. And I just tell the resident, just like put it in there, see what it looks like. It's only a K-wire. And then based on that, you know, use that as my sort of osteotomy guide. And then we can adjust it a little bit. So generally we put the pin too far proximal to take too much. I say, okay, we'll just stay inside of that and use this as your aiming guide. I've started and I did one today, doing a formal capsulotomy, and then that way I can do a debridement of the joint too and take down some of the bones versus the scaphoid. And that's been helping me find the orientation for the styloidectomy a little bit better. And it's only just, you know, a few millimeters distal to your your Descurvain's approach, and just open it up. And then I like to irrigate the joint out, get any, you know, CPBD crystals out of there, gout crystals or whatever it is.
Awesome. Thanks.
Mm-hmm. All right, Nina.
I also, funny enough, when I was a fellow, actually, Hotchkiss used to say that too. He wouldn't fix SLs either. And he's like, Nina, it doesn't matter. These people, like, what is the surgery going to do? They're just going to be like stiff and stuff like that. I would just rather do a salvage procedure. So it's funny that you mentioned that as a thing. I feel like the older school surgeons, and I think it's what it is it's because it goes all around, right? Like there's some on vogue, like the 3LT prior to me doing arthroscopic, that would have been my go-to. I was like,
Mhm.
I liked it. It feels good and stuff like that.
Mhm.
Now I've tried to do arthroscopic, but I don't think it's wrong. Like arthroscopic ones are extremely hard.
Mhm.
They're extremely hard. That is not something that, even though it looks great and like Wags has done so many, I think that's why it's adept, but that's not something I think trainees must know or do in their
Mhm.
first 2 years, quite
Mhm.
frankly.
Can you comment at all about the like chronicity of the ligament and just doing the repair? Because that, I mean, we talked a little bit about in the panel that we had, but I mean, what's the thought process there? Because you're doing a bone tunnel and whatever's there will come back. You don't need a graft with it, or what?
Yeah, I
Have you
think
guys talked about this in your
there's like
conferences?
some like there's always, if you're gonna do it like just capsulodesis, but there's something there all the time when you do it, but and then otherwise you just have to do the graft and go around and stuff like that. In essence, it's like it's a front and back, right, that you're doing, and you're just like tethering it.
Mhm. Mhm.
It's hysterical because I remember when I was a fellow, I was at HSS, and Eugene Eck, actually from Australia, was my co-fellow, and he talked about how you should do a box technique. Everybody told him at HSS told him he was stupid as a fellow, as a fellow. And then look at that. I told him, I guess several years later, I told him like, so he was all upset about it, of course.
Wow.
But it's crazy. Like I think trends go, but I think when you go front and back and stuff, I get so nervous even with arthroscopic. Like the volar thing just scares me. Even though you have an incision there, it scares me because you don't really see that well, to be honest. Like you could actually get a branch, you could do with something. So I think it's very difficult.
Mhm.
But the techniques, I think the only good thing about I find the arthroscopic is that maybe it's a little less invasive. Maybe it helps.
Mhm.
But in the end, like I usually do like 8 weeks
Mhm.
if I remember. And then otherwise, if I forget, it comes out in 6 weeks because that's the orthopedic unit, right?
Yeah. Dr. Group, how do you do a reconstruction? What's your
You
preferred?
know, I've done the all dorsal with the internal brace, and I haven't done a ton of them, so I can't say that I've had the, gapping and failures yet. They might be lingering out there. But that's what we did in fellowship at UCLA. And I think, you know, as time has gone on, I've definitely, heard a lot of different perspectives. I've heard a lot of people talk about the Brunelli or the 3LT and kind of say that that's their preferred. I don't think I'm there yet for the arthroscopic front and back.
Mhm.
But I think if one came in tomorrow to my clinic, I'd probably do an all dorsal.
Mhm.
Yeah, that's just what I'm most comfortable with.
Mhm.
And it, I don't think I can deliver a better operation than that with what I know currently. I have been interested in the Rassel because I think that it probably more reliably closes the gap because you get compression through that screw. And I've actually wondered if you could instead, because usually say you repair your SL, you reconstruct it, and then you're putting in K-wires, let's say if you're doing like a MyTech repair and then you do K-wires, instead of that SL K-wire, you could just put in a small cannulated screw there and take it out at the same time as you take out your wires. And, I'd probably leave it for like 12 weeks.
Mhm.
And I've wondered if that would be a good way to close the gap temporarily while you're healing and prevent early gapping, and then take it out when you're taking out the rest of your pins that you bury. So I've thought about that idea. I haven't done it. So that is just something I've considered, but I don't know. I think like Joe said, the more you think about it, the more you talk to people and the more you read about it, you can just convince yourself to do so many different things and you're not really quite sure which one's the best one. So I don't know. I don't have a good answer either.
But I do think, for you guys as you're starting out, I think the addition of a staging arthroscopy is super helpful. Because you'll be in board's collection, you're gonna be worried, you're gonna be like remembering this talk, be like, they told me no SL reconstruction works, and I can't do what Wagner's doing with the scope. Like this is, and so taking the time, you have one, scope it, figure out if it's acute or chronic, figure out if it's reducible, and then go from there. It gives you time to think and think through things, and the patient still feels like they're getting something done. Because the acute just happened, just tore their wrist, put a a suture through it is so uncommon, at least in my practice. I don't know about Nina and Paul's, but they tend to be these sort of questionable, debatable timeline. So
I totally agree with that.
Never
Since
know.
And I will scope for like the distal radius associated SLs. That's the one time in a distal radius where I'll scope. And then I'll kind of, take that and decide what I'm going to do with it. And usually I'll repair the SLs in young people that I find for distal radius, but usually not in like 50 and above, or 55 and above. But I do like arthroscopy for that, certainly. And I agree.
The literature would indicate that you don't need to fix those SLs,
Mhm.
but again, who knows, right?
Yeah.
the literature probably support that we don't need to fix the distal radius either.
That's right, exactly. You can find anything. All right, well, Maureen, thank you so much. Do you want to stop the recording, Paul?
Yes. Good idea.
And then I'll show you a cute little thing, last thing before you go, Maureen.